Hi, everyone, and welcome to the deep dive. Today, we're getting right into something really fascinating. The aesthetics of millimeters. We're zoning in on the front of the mouth, the maxillary anterior region, the part everyone sees. And specifically, we're looking at this gap, the difference between what dental specialists see versus what patients, or really just everyday people, actually notice. So our deep dive today has two main parts. First, we'll unpack a study that looked at how people perceive implant crowns, depending on whether they replace a lateral incisor or a canine, very different teeth. And second, we're going to walk through a really practical decision-making framework. Basically, how do you decide between traditional braces, orthodontics, versus using restorations like veneers for quick alignment fixes, sometimes called instant orthodontics?
Yeah, it's a huge topic. It really gets to the heart of modern aesthetic dentistry, doesn't it? Balancing, saving tooth structure versus getting that immediate wow factor, that beautiful result. And the front teeth, I mean, they're critical. If you have missing teeth there or things aren't aligned right, every single decision feels like it carries so much weight. If we don't get it right in that aesthetic zone, well, it affects everything, right? How people feel about themselves, whether they smile freely, it's big.
Okay, let's start breaking this down. Part one,
Mm.
implant-supported crowns, or ISCs, right there in the aesthetic zone. Because replacing a front tooth, whether it's lost from, say, an accident or maybe it never developed, like with missing lateral incisors, it's got to be one of the toughest things in restorative dentistry.
Oh, absolutely. High stakes is the right word. And the aesthetics, it's not just the tooth itself. You've got the pink aesthetics, that's the gums, the shape, the color, the health of the tissue you see. And then the white aesthetics, the tooth shape, how light hits it, the texture, the color, it all has to blend. So when someone is missing a front tooth, generally you've got three main well-qualified paths you can take. One, you can use orthodontics to open up the right amount of space, then place a single implant. Two, you could use ortho to actually close the space, moving the canine tooth into the lateral incisor spot and then reshaping it. Or three, the more traditional route, a fixed bridge, usually supported by the adjacent teeth.
Right. And for this deep dive, we're really focusing on that implant pathway.
Yeah.
So you place the implant crown, the ISC, how well does it really look? How does it integrate? And crucially, how differently do the pros see it compared to, the average person? That was the key question in this big digital survey we looked at.
Exactly. It was a nicely set up study. They surveyed quite a few people, 207 laypersons and 184 orthodontists. And they basically showed them pictures, clinical photos of smiles, where an implant crown was replacing either the lateral incisor, let's call that ISCL, or the canine, the corner tooth ISCC. And the first job for everyone was pretty simple. Just look at the smile. Can you tell which tooth is the artificial one?
And the results there, I mean, the difference in identification was just huge. Pretty much confirmed what we'd expect, right? Orthodontists who are trained to see every tiny detail, symmetry, texture, gum contours, they spotted the implant crown correctly 89% of the time. And it didn't really matter much if it was the lateral or the canine they were looking at. High identification rate.
Yeah, 89%. Now, contrast that with the laypersons. The average person looking at the exact same high-quality photo, they only managed to pick out the implant crown correctly about half the time, 50%.
Wow, 50%.
That's really significant clinically. It tells you straight away that patients often just don't see the discrepancies that, for us, might scream clinical failure. The specialist is just operating on a totally different level of visual perception. It's a different world.
Okay, so lay people are much more forgiving in just spotting the difference. That's kind of encouraging in a way. But what about preference? Even if they couldn't always identify the implant, did they still prefer seeing it in one position over the other?
They definitely did. And interestingly, the preference was the same across both groups. Both the orthodontists and the laypersons significantly preferred the implant when it was in the lateral incisor position, the ISCL, much more preferred than when it was in the canine position, the ISCC. That was a really clear finding.
Okay, let's dig into that. Why? Why is putting an implant crown in the canine spot so much trickier, less forgiving aesthetically?
It really comes down to the tooth's shape and its place in the arch. Think about how your teeth are arranged. The canine is this big, bulky tooth. It's very convex, curved outwards. And critically, it sits right at the corner of your smile where the arch starts to turn back. It's often called the cornerstone of the arch for a reason. It catches the light because of that shape and position.
Okay, I see.
So trying to replicate that very specific shape, how it emerges from the gum, the way light bounces off it, doing that with an implant crown is incredibly challenging. Any little imperfection tends to stand out more. The lateral incisor, though, It's usually smaller, often a bit flatter, or even slightly tucked back compared to the central incisor in canine. It kind of blends in more easily. So it's just a much more forgiving spot to place a prosthetic tooth, less visually demanding.
And the acceptance rates from this study really drive this home, don't they? When they asked about the overall look, considering color, shape, and the gums together, for the ISCL, the lateral position, 54% of laypersons found it acceptable, which sounds okay.
But compare that to the orthodontists, only 23% acceptance for the ISCL. They are much tougher critics.
Right. And then you look at the canine position, the ISCC, acceptance drops even more. Laypersons down to 40%.
And orthodontists, a really low 10% acceptance rate for the canine implant.
10%?
Yeah. It tells you that for the pros, putting an implant in the canine spot is almost always seen as aesthetically compromised to some degree, even when it's done really well. The lateral position just gives you a better shot, statistically, at getting a result that everyone finds visually acceptable.
Okay, so position matters hugely. Now, what about the specific aesthetic factors themselves? Which ones do people prioritize? The study used that visual analog scale, the VAS score, right? Ranking tooth color, tooth shape, and gingival color, the gum color.
That's right. And looking at the orthodontists first, tooth color came out on top. Mean score of 9.0 out of 10, very important. Tooth shape was right behind it, very close at 8.8. And then gingival color, the pink aesthetics, came in third, significantly lower at 8.0.
Okay, so for specialists, color, shape, then gums, but all still rated pretty highly.
Exactly. It confirms that white aesthetics, the tooth itself, really dominate their perception, though they absolutely don't ignore the soft tissues. 8.0 is still a high importance score.
And how did the laypersons rank them? Similar order.
Similar order, yes, but they rated everything as less important overall compared to the orthodontists. For lay people, tooth color and tooth shape were essentially tied. Both averaged around 8.0, and both were seen as significantly more important than gingival color, which they rated down at 7.2.
So everyone agrees. The tooth itself, color, and shape is the main event. White aesthetics drive the perception.
Generally, yes. But, and this is where it gets really interesting, I think, there was this one fascinating exception. Remember, laypersons were generally way more forgiving than the orthodontists, higher acceptance rates for almost every case shown.
Right.
Except when you isolate gingival color, specifically around the implant in the canine position, ISCC.
Wait, hang on. So lay people are generally okay with bigger issues. They rate gum color as least important overall. But suddenly, for the gum color around the canine implant, they become as critical as the orthodontists.
Exactly. For that one specific parameter, gingival color index, or GCI for the ISCC, the acceptance proportions between laypersons and orthodontists were basically equal. Both groups were equally critical.
Why? Why that specific spot? If they tolerate midline shifts and slightly off shapes, why does the gum color around the canine suddenly trigger such a strong reaction, even in untrained eyes?
I think it's probably a mix of things: anatomy, visibility, psychology, maybe. The canine, like we said, is the corner tooth. It's prominent. It's right there at the transition. So any discoloration in the gums right there, if it looks gray or red and inflamed or just doesn't blend with the tissue next to it, it's like a flashing red light. It's highly visible. Maybe if there's a slight issue around a smaller, more recessed lateral incisor, the way the light hits it, the shadows, it can kind of mask the problem. But the canine, it's big, it's curved outward, it catches the light, your eye is drawn right to that gum line. If the soft tissue isn't right there, it just shatters the illusion of naturalness. Doesn't matter if you're a dentist or not, you see it. It's like a visual alarm bell going off.
That's a really powerful point. Soft tissue problems around prominent teeth are just universally noticeable. And that idea that the frame, the gums, is just as crucial as the picture, the tooth, that leads us perfectly into the next big question, doesn't it? The huge clinical decision. When do we move the frame orthodontically, and when can we just essentially repaint the picture with restorations?
Precisely. This is the core of so much interdisciplinary treatment planning. Are we going for conventional orthodontics braces, aligners, months or years of treatment? Or can we achieve the patient's goals with what's often called instant orthodontics, using bonded porcelain, veneers, sometimes crowns, to quickly fix alignment, spacing, or shape problems?
And the guiding principle here, it has to be doing the least invasive thing that works.
Right.
That meets the aesthetic needs, but also functions well long-term.
Absolutely. Least invasive dentistry should always be the goal.
But I mean, defining least invasive can be tricky, can't it? Because any restoration needs upkeep, potentially replacement down the line. So how do you systematically decide which path is truly better for the patient's biology in the long run? We need a system. And the source material we looked at laid out a really useful clinical flow sheet, basically a series of guiding questions.
Yes, it's a very helpful decision matrix. We should probably walk through it step by step.
Yep.
So, question number 1, the most fundamental. Will these teeth need restoration anyway? Does the patient already have big old fillings or maybe crowns that don't match or deep staining inside the tooth that won't bleach out? If the answer is yes, well, then restorative treatment is happening regardless of alignment.
Okay, that seems like it simplifies things right off the bat. If you need veneers anyway, why bother with 18 months of ortho?
Well, hold on. It's not quite that simple. Even if restorations are inevitable, orthodontics might still be the better choice if it leads to a more predictable, more conservative final restoration. Think about a tooth that's severely rotated, sticking way out. If you try to just slap a veneer on it to make it look straight, you might have to grind away a ton of healthy tooth structure just to get it back in line visually.
Ah, right, to avoid it looking too bulky.
Exactly. That's aggressive prep. It compromises the tooth's strength, maybe gets close to the nerve. In that case, taking the time to orthodontically derotate the tooth first means the final veneer requires minimal, much more conservative preparation. And conversely, if the teeth are perfectly healthy, just slightly crooked, then traditional ortho is almost always the most conservative option because you're not removing any tooth structure at all.
Okay, that makes sense. Question 2 then dives into function. Can the occlusion, the bite, be managed restoratively? This seems like a big hurdle for the instant ortho approach.
It often is, especially if you're dealing with significant tooth wear or a really deep bite or just a generally tricky occlusal scheme. You simply can't fix major skeletal issues or severe bite problems with just porcelain veneers. It doesn't work functionally. Take advanced wear on the front teeth. A huge advantage of ortho is that it can intrude those worn teeth, gently push them back up into the bone.
Intrusion.
Yeah.
Okay, why is that helpful?
Because it creates vertical space. Space for the restorative dentist to add length back to those worn teeth without having to open the patient's bite overall. If you try to just add length restoratively without intrusion, you might end up needing to build up the back teeth too, just to make everything fit. That means potentially restoring healthy posterior teeth, which you really want to avoid.
Got it. So ortho can prevent a cascade of further restorations.
Precisely. Or if you have something like an anterior crossbite or an edge-to-edge bite or really poor canine guidance. Orthodontics isn't just an option, then. It becomes a necessity for stable long-term function.
Okay, moving to the gums again. Pink aesthetics. Question 3. Is the highest point of the gum line, the apical-free gingival margin, aesthetically acceptable? This gets at the gummy smile issue, right?
Exactly. If the patient shows a lot of gum when they smile, and the reason is because a tooth is tipped too far forward, too labially, just putting a veneer on isn't going to fix the gum level. In fact, trying to mask that labial position with a restoration often just makes the gum margin look bulky or inflamed. It doesn't address the underlying tooth position.
You can't just surgically lower the gum line in that situation?
Not predictably, no. We have procedures like connective tissue grafting to cover exposed roots, yes. But we can't reliably pull the gum tissue down coronally over a tooth or a restoration if that tooth is already positioned too far forward. The biology doesn't support it well. So if that high gum line is a major aesthetic concern, orthodontic intrusion moving the tooth and it's supporting bone and tissue vertically is the most predictable way to get that margin where it needs to be.
Okay, intrusion is key for high margins on proclined teeth. Question 4 shifts focus slightly to the space between the teeth. Are the papilla levels harmonious? We're talking about the dreaded black triangle here.
Yes, the open gingival embrasure. Black triangles can happen for various reasons, maybe big spaces between teeth or bone loss. But critically, they often happen when teeth are crowded or rotated. Why? Because the bone level between the roots might be too low or the roots might be too close together, squeezing out the papilla.
So how does ortho help that?
This is really important for clinicians to grasp. Orthodontics is often the only truly predictable way to fix papilla height issues caused by malalignment. Periodontal surgery, trying to graft tissue or regenerate bone in that tiny interproximal space. Very unpredictable in the aesthetic zone, high risk of failure. But orthodontics, by physically moving the teeth and their roots into the correct position, brings the underlying bone and soft tissue along with it, moving them coronally. This allows the papilla space to fill in naturally and predictably as the tissue matures around the new tooth positions.
Whereas restorations can only try to close the gap from the top down.
Right, which usually leads to long, wide, unnatural contact points between the restorations. Difficult to clean, not ideal biologically or aesthetically. Ortho fixes the foundation.
Makes sense. Question 5. Can an acceptable contour and arrangement be created restoratively? This is about the final shape and size, especially with to-length ratios.
Yes, and this absolutely demands a diagnostic wax-up or a digital simulation before you commit to instant orthodontics. You have to mock it up. You need to see, if I close the space restoratively or align this tooth with a veneer, are the front teeth, especially the central incisors, going to end up looking weirdly wide or too narrow?
People talk about the golden proportion.
Right, and while those mathematical ideals exist, the most critical rule visually is usually symmetry and proportion of the central incisors. They dominate the smile. If you can get the two central incisors looking right proportional width and length and symmetrical to each other, you often have more leeway with the lateral incisors. They can sometimes be a bit wider or narrower than ideal as long as they match each other.
So focus on the centrals first.
Absolutely. If your restorative plan forces you to create central incisors that look obviously too big or too small, that's a red flag. The smile aesthetics will likely be compromised, and you need to reconsider orthodontics to get the spacing right first.
Okay, now we get into the really crucial biological limits. Question 6. Are structural compromises necessary? Basically, how much tooth do you have to cut away for the instant fix?
Exactly. This is about the biological price tag. To make a tooth that's sticking way out labially look straight with a veneer, you often have to grind off a lot of the front surface. Sometimes you're removing almost all the enamel, getting deep into dentin. That's aggressive.
Almost like prepping for a full crown sometimes.
It can be, yeah. Or conversely, if a tooth is tucked way back lingually, you might have to remove a lot from the back surface to allow space for the porcelain veneer on the front. Otherwise, the final tooth feels thick and bulky. For young patients especially, or anyone with otherwise healthy, untouched teeth, if the only way to achieve alignment restoratively involves that kind of aggressive preparation, getting close to the pulp, significantly weakening the tooth, then the time investment for orthodontics becomes almost ethically mandatory for long-term conservation.
And that leads directly to the final question, number 7. Are the biologic consequences acceptable? This covers things like nerve health and gum health.
Right. If your planned tooth reduction is so deep that you risk exposing the pulp, meaning the patient might need a root canal treatment just to accommodate the veneer, that's usually a major reason to stop and choose ortho instead. Elective endodontics for purely cosmetic alignment is rarely justifiable.
And the gums.
The other big one is violating the biologic width. If, because of the tooth's misalignment, the edge of your restoration, your margin, has to be placed way down below the gum line, deep into where the tissue attaches to the tooth, that's a recipe for disaster.
Why is it so bad?
Because the body requires a certain amount of space between the bone and the restoration margin for healthy tissue attachment. If you invade that space, you almost invariably get chronic inflammation, bleeding gums, potentially bone loss over time. The gum tissue just never looks healthy or stable. So if correcting the alignment restoratively forces you to violate that biologic width, especially with severely overlapped teeth, orthodontics is the only way to ensure long-term periodontal health. The convenience of a quick fix just never outweighs those serious biological risks.
Wow, okay, that's a really comprehensive framework. It forces you to think about function, biology, long-term stability, not just the immediate visual change. But even when you make that decision, say you go the restorative route, you still have to deal with those subtle perception gaps we talked about earlier, those tiny differences in millimeters that specialists see but patients often don't.
Exactly. Now we shift from the which treatment path decision to the how perfect does it need to be question. And this is where we bring in that fascinating research, like the work by Kokic and colleagues. They actually put numbers on it. They quantified, in millimeters, the exact thresholds where different aesthetic discrepancies become noticeably unattractive to different groups, orthodontists, general dentists, and laypersons.
Right, let's look at some of those numbers, focusing on the sensitivity differences. Take crown length first. Imagine a central incisor is a bit short, maybe due to wear or the gum line being slightly high. How much shorter does it have to be before people notice?
Okay, for the specialists, the orthodontists, the threshold is incredibly low. They rated the smile as significantly less aesthetic if the central incisor was short by just 1.0 millimeter.
1 millimeter, that's tiny.
Tiny. General dentists were a little more forgiving. They noticed it around 1.5 millimeters. But laypersons, the average patient, they didn't really perceive the difference as significantly unaesthetic until it reached 2.0 millimeters.
2 millimeters versus 1, that's double the tolerance for the patient compared to the specialist. That gap is huge, isn't it? It feels like that's where so much clinical judgment and patient communication has to happen.
It absolutely is. We might be striving for that perfect 1.0 millimeter symmetry, but the patient might be perfectly happy with 1.5 millimeter, or even not notice the 2.0 millimeter discrepancy. It allows us sometimes to be a bit more conservative. If achieving that final half millimeter of perfection requires a much more aggressive surgical approach, for example, we have to weigh that against the fact that the patient might not even perceive the less perfect but more conservatively achieved result as being deficient.
Okay, what about crown width? Let's look at the lateral incisor again, since we know it's a bit more forgiving. How much width difference is noticeable there?
Here, the tolerance is even greater across the board. Both the orthodontists and the general dentists needed a pretty substantial 3.0 millimeter difference in width before they rated it as significantly less attractive.
3 millimeters. That's quite a lot visually.
It is, and laypersons. Even more forgiving. They needed a 4.0 millimeter difference before it registered as a significant aesthetic issue.
4 millimeters. That gives you a lot of wiggle room clinically, doesn't it?
Tremendous. It means if you have a patient, say, with naturally smaller lateral incisors, but they're symmetrical, if making them the ideal width would involve adding less than 3 or 4 millimeters, you know that purely from a perception standpoint, restorative work might not be necessary if the central incisors look good. It helps avoid unnecessary treatment cycles.
Okay, back to the gums. What about that open gingival embrasure, the black triangle between the central incisors?
Orthodontists, again, were the most critical. They found a 2.0 millimeter opening to be unacceptable aesthetically, but general dentists and laypersons, they needed the opening to be larger, around 3.0 millimeters, before they rated the smile as significantly less attractive.
So again, patients tolerate those small gaps more readily, which is good news perhaps after ortho sometimes when tissue doesn't fill in perfectly.
Exactly. It helps manage expectations and define realistic treatment endpoints.
Now, this next one, midline deviation, this finding really surprised me in terms of the professional versus layperson view.
Oh yeah, this one is always striking. How far off can the midline between the two front teeth be from the center of the face before it looks wrong? Only the orthodontists showed significant sensitivity here. They rated smiles as less aesthetic when the midline was off by 4 millimeters.
4 millimeters, that feels like a lot.
It is a lot visually, but here's the kicker. General dentists and laypersons showed almost no significant difference in their aesthetic ratings, even when the midline was off by 4 millimeters.
So the orthodontist sees it clearly at 4 millimeter and flags it, but the patient might not even register it as a problem.
That's what the data suggests, which raises huge clinical and ethical questions, doesn't it?
Absolutely. How do you decide when to stop treatment? If getting that final millimeter of midline correction requires another 3 months in braces, is it worth it if the patient likely won't perceive the difference?
It forces a really important conversation with the patient about diminishing returns. We have to be honest. Look, we can spend more time getting this absolutely perfect according to professional standards, but you personally may not see a significant improvement from where we are now.
If function is good and the major aesthetic issues are resolved, sometimes chasing that last bit of invisible perfection isn't in the patient's best interest, especially if time or cost is a major factor for them.
Okay, one more major perception threshold. The gingiva to lip distance, the gummy smile. How much gum show is too much? Again, a significant difference. Orthodontists started rating smiles as unaesthetic when the gingival display reached about 2 millimeters. General dentists and laypersons, however, were much more tolerant. They didn't find it significantly unaesthetic until there was 4 millimeters or more of gum showing.
4 millimeters. That's quite a bit of gum display that patients find acceptable.
It is, and it's really important when considering complex treatments like orthognathic surgery, jaw surgery, or extensive orthodontic intrusion just to reduce gum show. If the patient falls within that 4 millimeter tolerance range, you have to question if such invasive procedures are truly warranted based on their perception.
Now, we should add a little nuance here, circling back to the canines, right? Because while that study showed general tolerance for overall gingival margin discrepancies, there was other research looking specifically at asymmetry in the canine gum levels.
Yes, that's a crucial distinction. That specialized study found that while laypersons might tolerate 4 millimeters of overall gum show, specialists Orthos, pros, endos could detect asymmetry in the gum margin height between the two canines when the difference was as small as 1 millimeter.
So even if the overall gum level is acceptable, if one canine gum line is 1 millimeter higher or lower than the other, the specialist eye picks it up immediately.
Correct. It reinforces that idea of the canine being a critical visual landmark. Symmetry at the corners of the smile seems to be highly valued by professionals. Laypersons were still a bit more tolerant, needing about 2 millimeters of asymmetry at the canine to notice it significantly, but even that's tighter than their tolerance for overall gum show or midline issues.
So the takeaway seems clear. Specialists are generally working on a 1 to 2 millimeter detection threshold for many aesthetic issues. Patients, often tolerant up to 3 or 4 millimeters, sometimes more, except maybe for gum color or asymmetry around that highly visible canine.
Precisely. And knowing this difference is absolutely paramount when you get into treatment planning, especially when different specialties need to work together.
Right, that interdisciplinary communication. It's not just nice to have, it's essential.
Non-negotiable. Especially if teeth are being moved orthodontically, specifically for future restorations, the restorative dentist absolutely must communicate the final vision to the orthodontist. It's not just about creating space, it's about where that space is and, crucially, where the root of the tooth needs to end up.
How does the restoration plan affect where the orthodontist needs to put the root?
Think about it. If the final plan is a very thin, conservative porcelain veneer on a healthy tooth, the orthodontist might position the root slightly differently than if the plan is to place a thicker, full-coverage crown because the tooth is badly broken down. The final restoration needs space, and the root position dictates the emergence profile and where the final margin will sit relative to the bone and gum. So the orthodontist needs to know the desired final incisal edge position, the desired axial inclination of the root, the desired vertical position, all dictated by the restorative plan.
And the timing of different procedures matters too, right? Like if gum surgery is needed.
Absolutely. If you need something like crown lengthening, maybe using osseosurgery to correct a biologic width problem or achieve gum symmetry, the team ortho, perio, restorative needs to decide when that happens, before ortho, during, after ortho, but before final restorations. Each has implications for tissue healing and stability. It has to be planned as a sequence.
Okay, let's pivot slightly and talk about a specific treatment that really highlights this need for integrated planning. Canine substitution. This is where you move the canine into the missing lateral incisor spot. It's often considered a very conservative option, especially if implants aren't feasible. For some reason, maybe not enough bone, patient's too young, cost issues.
Yes, it's a great option in the right case, but it's very demanding. You're essentially asking a big, pointy tooth to pretend to be a smaller, flatter tooth, both visually and functionally.
So what makes someone a good candidate for this kind of camouflage?
Well, first you look at the occlusion, the bite. Ideally, you want someone with an angle class 2 relationship, where the upper teeth are a bit ahead of the lower, usually without crowding in the bottom arch. That makes space management easier. Or sometimes a class I case where the bite is normal can work if the patient needs lower teeth removed anyway, perhaps for crowding. Functionally, the goal is usually to get anterior group function. That means when the patient slides their jaw sideways, several front teeth share the load, including the reshaped canine acting as a lateral, and often the first premolar, which is now acting kind of like the canine.
Okay, so the bite has to work out. What about the aesthetic factors? This seems like the bigger challenge.
It really is. Aesthetically, the ideal candidate should have a reasonably balanced facial profile to start with. Crucially, the color of the natural canine needs to be a pretty close match to the central incisor next to it, or at the very least, it needs to be a color that you think can be successfully bleached without causing major sensitivity issues long term. A dark yellow canine next to a bright white central is very hard to camouflage.
And the shape. Canines are so different from laterals.
That's the key screening factor. You look closely at the canine's natural shape. Ideally, you want one with a relatively flat front labial surface. This means less grinding is needed to reshape it. And maybe most importantly, you look at the width of the canine right where it meets the gum, the cement-enamel junction, the CEJ. You often need an X-ray to judge this properly.
Why is the width at the gum line so critical?
Because the CEJ dictates the tooth's emergence profile, how it appears to come out of the gum. Canines naturally have a wide, bulky CEJ. If you move that into the lateral spot, it tends to look thick and square right at the gum line, which screams canine. If you can find a patient whose canine has an unusually narrow CEJ, it makes the reshaping process much easier and allows you to create a more delicate oval emergence that looks much more like a natural lateral incisor.
But even with a good candidate, you're still going to have to do significant reshaping, right? Grinding down the cusp, narrowing the tooth.
Almost always, yes. Significant reduction in reshaping or equilibration are usually needed. You have to narrow the mesial and distal sides considerably. You absolutely have to flatten that pointy canine cusp to mimic a lateral incisor edge. And doing that level of grinding often exposes the underlying dentin. If you then need to bleach it aggressively for color match, you're increasing the risk of sensitivity.
So it often means further restorations are needed down the line anyway.
Frequently, yes. It means that even after ortho and reshaping, a final conservative restoration, often a porcelain veneer, or maybe some composite bonding is needed to really dial in the final color and perfect the contours, especially closing any minor gaps or refining the edges where tooth structure was removed. This is why the diagnostic wax-up before you even start ortho is so vital for canine substitution. It tells you exactly how much reduction will be needed so everyone knows what they're getting into.
Okay, this brings us neatly back around one last time to that decision framework. Let's try to summarize. Who is the perfect candidate for skipping orthos altogether and going straight for the restorative-only approach, the instant orthodontics?
Right. The ideal patient for just veneers or crowns to fix alignment. It's someone where the speed and simplicity genuinely outweigh any biological compromises. So first, like you said, they must need restorations. Anyway, trying to align perfect, healthy teeth with veneers is almost always overtreatment. Second, they need an ideal and stable occlusion. No major bite issues, no need to level arches or change the vertical dimension significantly. Their bite has to already work well.
Third, the gums have to be manageable.
Exactly. Their free gingival margin and papilla levels must be manageable, meaning no really high smile line revealing gum levels that are way off, especially on teeth tipped forward. And no significant black triangles or low papillae that really need orthodontic root movement to fix properly. Fourth, you have to be able to create an acceptable contour and arrangement restoratively, especially ensuring the central incisors look proportional and symmetrical. Your wax-up confirms this. And finally, number 5, perhaps the most important. Achieving this alignment must require only conservative tooth preparation.
Meaning no major structural damage or biological harm.
Precisely. No aggressive grinding into deep dentin, no elective root canals needed just for alignment, and absolutely no placing restoration margins deep into the gum tissue, violating the biologic width.
So if a patient ticks all those boxes, instant orthodontics might be a great option. But if they fail even one of those criteria, especially the structural or biological ones,
then the scale tips heavily back towards conventional orthodontics, even if it takes longer. The long-term health of the teeth and gums has to be the priority.
it really comes down to those millimeters again, doesn't it?
It really does. That tiny difference between what we see as professionals, that 1 or 2 millimeter discrepancy that jumps out at us, and what the patient perceives, which might be a 3 or 4 millimeter tolerance. Our job, ultimately, is to bridge that gap. To use our objective precision, our drive for that near-perfect result, but temper it with the patient's subjective reality, their actual perception. And through it all, we have to hold on to that core principle, preserve healthy tooth structure for the long haul. That's the art and science of it.
That leads perfectly to a final thought for everyone listening. We've talked a lot about these perception gaps, like a 4 millimeter midline deviation that specialists see, but patients often don't. So the question is, since patients often can't perceive these very subtle aesthetic differences, should we, as dentists, always push for that absolute, maybe barely perceptible 1 millimeter perfection, even if it costs significant time and resources? Or should our focus perhaps shift more towards ensuring functional stability and correcting the major visual improvements, the things the patient can truly see, appreciate, and value? Something to think about. Thank you for joining us for the deep dive.
Bye-bye. 1 second.